Okay, excellent. So now it's been recording, which was asked of us to do. Thank you. I'm Michael Pasha-Orlo. I'm calling in from Boston University School of Medicine. Thank you for joining. I'm here with Lori Hinault, who's the project manager for this work. This project represents a project that we did with PCOR. And was from a Eugene Washington PCOR Engagement Award. I've been running with Lori for the last 8 years the Health Literacy Annual Research Conference, and for the past 2 years, with the support of PCOR, we've really significantly expanded the work of examining the intersection between health literacy and patient-centered outcomes research, and that's really the focus of today's webinar. On the screen in front of you, you should have the link to our Health Literacy Conference, and much of the materials, all the presentations from the last 8 years, you can find on that site. But more relevant to today's talk is the last 2 years, where PCOR and PCOR really were the focus of the work at the Health Literacy Annual Research Conference. 2015 with the keynotes of Michael Wolf and Cindy Brock, and in 2016 with keynotes of Russell Rossman, Alyssa Fernandez, and Ebony Bulwar. With that, I want to just start off the conversation by talking about the goals of the session, which really can be exhibited like this, which is to what extent and how do the fields of health literacy and patient-centered outcome research intersect, and how can we envision them to be synergistic? Because we have limited time together, I'm just going to be really highlighting some of the most important features. But to start, I think I have to define some terms. Patient-centered outcomes research really helps people and their caregivers communicate and make informed care decisions, allowing their voices to be heard and assessing the value of healthcare options. I'm going to kind of take it as a given that people know what PCOR is and is about more than health literacy. So let me just spend a little bit more time about literacy, and in particular health literacy. Now, when we think of literacy, really you have to think of a domain of function, specific things that people have to do. Literacy really is competence in a specific set of skills. We can legitimately talk about a set of skills that a person needs, for example. We can legitimately talk about the set of skills that people have to, say, fix a car or to interact with computers, or the area that I work in, which is health literacy. This is the official definition of health literacy according to Healthy People 2020. The degree to which individuals have the capacity to obtain, communicate, process, and understand basic health information and services needed to make appropriate health decisions. And I'm going to go through this definition in a few steps because actually I think it basically fails as a definition of health literacy. It's not appropriately specific, and it also leads us in the wrong direction in ways that I think are very important to point out. The first problem with this definition is that it includes the word basic. And really, that's not the right mindset. You know, if you're a person who has to decide, you know, for my cancer, do I choose chemotherapy or radiation or surgery or watchful waiting, whatever my choices are going to be, to be empowered to make that decision, that's critical for you at that point in your life, is irrelevant for many, many other people. There's no way to define a basic set of skills or in this area. You know, if you have asthma, there's specific skills, very specific things that are critical for you in the self-care space for asthma that are relevant to another person. So I think the word basic really has nothing to do in this, really is wrong in this definition and should be thought of as really according to the contextual demands. The next thing is that it's not just information and services, it's also skills. There really are skills that people need in order to be empowered in healthcare. This will involve things like how to use your inhaler, or how to use a glucometer, how to interpret results. There are many, many skills, how to interact with people in ways that you can communicate your needs and in ways you understand what they're telling you. There are many, many skills that are particular to healthcare. And the next thing that I think is really the wrong direction in any kind of definition is the word appropriate. Appropriate to whom? You know, I don't think the goals of this field are that the patient should act appropriately. The goals of this field are that the person should act in an informed manner, in an empowered manner. And that's really the focus, not appropriateness, but informed, empowered. Lastly, I very much think it's important to point out that the definition, by using the word individuals, can get us in the wrong mindset. Anything that you say about the individuals, you have to say about the system. How can we talk about a person having a limited skill set when actually the problem is the unnecessary and unbearingly overcomplicated manner in this healthcare system acts? If we talk about the individual's limited skills, we also have to think about, well, the efficacy of the providers, that they shouldn't be talking in jargon all the time, or the astonishing complexity of enrollment for benefits and navigating our very complicated healthcare system. We, in fact, have really an extremely complex system, and much of that complexity is unneeded. So we can talk about things at the individual level, how a person can understand a glucometer or interpret glucose results, for example. But there's also things at the system level all the time, obtaining information about illnesses, participating in decision-making and informed consent, enrollment in insurance plan, and there are many, many, many other examples. And this problem is getting more and more complex. There's really too much information, not enough time. If I asked you, you know, is vitamin E good for you? Well, you have to think about it, because actually the information is changing all the time, and it's really complicated. And we approach people for heavy cognitive tasks when they're not at their best, when they're sick, when they're scared, and we expect to try to have some kind of really complex conversations about it. And over time, this has been even more complex. We have direct-to-consumer advertising, direct-to-consumer genetic testing, more self-care, more forms, more tests, and ultimately, there's been a movement. I'm all for the shift that we've been making from paternalism towards shared decision-making. I'm all for it. It's the right direction. But we should acknowledge that that shift includes a new agenda, an effort that we have to massively empower patients to be able to, people to be able to participate in these conversations. The shift from paternalism to shared decision-making is also a shift where we have to, for that to work, we have to embrace the insights of the field of health literacy. Literally, the whole emergence of PCOR comes from that shift, comes out of the shift away from paternalism. It's the right move, but in order to do it, to succeed, we're going to have to figure out how to empower patients to be able to be fully active in those roles. So there are different conceptual domains for health literacy. There are basic literacy skills, prose, how to understand sentences written in sentences, document literacy. This is, oh, I put my name here, I put my social security number here. But it's also many other kinds of documents. The pill bottle, for example, is a very particular type of a document in the healthcare context. You have to know lots of information that are culturally defined. There's this word refills at the bottom, and that means you go to the pharmacy and they put more medicine in there. That's not how it's done in many other countries. So the documents in health literacy, in the healthcare space are also significantly contextually confined. You know, why is it that the largest thing on the pill bottle is typically just an advertisement for the pharmacy. You know, I give people medicine, say for diabetes, I say, how's it going with your metformin? If they say back to me, oh, everything's fine, I finished it, you know, that we didn't succeed. That means we didn't succeed, we didn't communicate adequately. And there are many, many examples like this. If I say to a patient, we talked about not eating red meat, you know, how's that going? You know, if the person says, yeah, I did exactly like you said, you know, I don't eat red meat anymore, I cook it all the way through. These kinds of examples means you have to listen to patients, understand what they're coming from, and make sure that our communications, to make sure our communications are successful, we need to check and make sure that we're actually communicating what we think we are communicating and empowering patients the way we hope. So there are other conceptual domains, all the self-care tasks that people have to do that are disease-specific. Interactional literacy, this is how we communicate to providers as patients and how we communicate back to them and understanding each other adequately. This is all also the case in the public health domain. Navigation, how to maneuver your way. This piece of paper means that I go to the pharmacy. This one means, you know, I go to this specialist. How do I get there? And all the things that need to be done. How do I get my benefits? So the next thing I wanted to do is to show you some data about the prevalence. If I say, well, how common is it that that adults in America would have low health literacy? Well, you should say, well, how are you defining it? And what tests are you talking about? Because it's unfair to just say, what portion of America has low health literacy without, saying something more about how these things are defined and measured. So one thing that I've done here at BU, here with my group, is we've created a health literacy tool shed. These are measurement tools that measure literacy at the individual level. This is different from tools that measure, the literacy burden of a healthcare system or providers' communications. This is simply a tool shed of literacy measures at the individual level. And if you go there, please, you can learn a lot about these tools and for different contexts. There are, at this point, there are 129 tools in the tool shed, different languages, different contexts, and we have more in the queue to get on here. My putting tools in the shed does not mean that I endorse that tool per se as the best tool for you, but it just means that it will link you to the tool and also link you to the validation studies that back up the tool. But I don't want you to misunderstand. I don't really advocate for people to use these clinically, and that's a whole other conversation maybe, but these are mostly for research purposes. In a clinical context, I think you have to you should be a patient-centered. You should find out what this patient needs to know and evaluate that person's skills for those tasks in a teach-to-goal manner. And if people want to talk more about that, I'm happy to later on. So now I'm going to show you data. I'm going to ask, how common is it that people could have low health literacy? This is already a bit old, but it hasn't changed. And this is from the National Assessment of Adult Literacy. From 2003, this is a 20,000-person household survey of PROS documented quantitative literacy and included a subset of items that are health literacy oriented. And in this survey, there are 4 levels of skills: below basic, basic, intermediate, and proficient. A person with below basic skills, typically, if given a simple appointment slip, could circle the date of the appointment on that slip for that task. But a person at below basic typically, for example, would not be able to, if you gave that person a pill bottle that said, please take 2 pills 3 times a day, typically would not answer the question correctly, how many pills do you need to take out of this bottle for 1 day's worth of medicine. So that gives you a sense of what below basic, basic, intermediate, and proficient. Just briefly, for the sake of time, I'm going to move on. And this is the United States. 14% of all adults at below basic and 22% at basic. I should say that about 3% of the United States could not sit for the screener, that is either from dementia or from absolutely no English skills. This is a test in English. there's clearly a whole conversation to be had about low English proficiency and everything, but really the large group, the large population of below basic and basic English is the first language. On the next slide is by race and ethnicity. These are very, very large effects, extremely large effects, and I and some others have, over the last decade, been showing in a series of studies how these phenomenon really are drivers of health outcomes and disparities of health outcomes. These clearly track with income and with education. And so really the conclusion at some level is that we have to, is to fulfill the primary educational objective in society. One of the things that this field really does in health literacy is call to question the basic underlying justice of the education system that in many cases really reflects local property taxes, baking into the system class phenomenon. And you can say, hey, but you were talking about health literacy. Well, yes, education level is related to health literacy in very important ways, but that's certainly not the whole story. Let me move on for sake of time. This is data from the National Assessment of Educational Progress. So this is from 2015, also data collected by the Department of Education. This is for 12th graders, high school students in 12th grade, and reading achievement by race and ethnicity. Also very, very large effects, and so this means that even when children do stay in school to 12th grade, for example, that there still are significant barriers, and the quality of education really does vary significantly in different school districts. On the next slide is for math, and you can predict for yourself if it's going to be better or worse in math. Yes, worse. And when you look at something like this, really you have to say to yourself, gosh, all of the things that we throw at people with mathematical concepts in it, risk and chance and all these different things, prediction and everything, what do we think we're actually communicating? And this is just a huge issue in public health and in healthcare, but also I think has deep connections into patient-centered outcome research, which we're now going to turn to pretty soon. I just wanted to point out that, these numbers are in the context of actually significant improvements in high school graduation, high school diploma, and GED in the United States over the last decades, and yet there are still deep racial and ethnic disparities, and the value of that diploma really does vary significantly. Here's another project just to point out as another resource for people. People can go to this website out of UNC. This will show you local area out of a predictive model that I and others have worked on down to the census tract level to show people the rates of low health literacy around the country, and you can go there and look at local area variation. So why does this matter? Why does all this matter? It matters because almost everywhere people have been looking at this factor, health literacy, has been connected to worse health outcomes in a whole array of settings and many, many more since I made this slide. I don't have time to go through all of this and all its detail. That would be a whole talk. But I just want to point out some information about mortality. There's 5 studies that have linked health literacy to mortality. This is maybe one of the best ones. This is about 3,500 people followed from the age of 66 once they're in Medicare in 4 cities around the United States. And this shows mortality estimates followed over the course of 80 months with a hazard ratio of 1.52. This is adjusted for BMI, smoking, diabetes, adjusted for income. These are robust findings and large findings. It's akin to adding a whole other chronic disease like diabetes to a population. So let me turn towards the specific task at hand, which is how, now that you're, I hope, thinking a bit more deeply about health literacy, how does that intersect with when we think about stakeholder engagement in PCOR, the influence on all the data collection that we do and everything that we do in that space, and then also on PCOR-oriented interventions. So basically, for stakeholder engagement, one of the questions that came out of our conferences is who will be effective stakeholders to represent this phenomenon, this health literacy thing, which really, because health literacy is such a cross-cutting influence on healthcare and public health, who can represent these perspectives? And really, it's going to be a mixture of people who have limited literacy themselves, and then other types of professional stakeholders who are knowledgeable about this space. And as you make your stakeholder engagement plans and as you think about how this is going to be done, how to get connected to those kinds of participants in your activities. Effectively, I hold, and many others at the conference presented, that without these perspectives, that it's really quite easy to fail to understand the experience of people who have limited health literacy and to respond to their needs. When you step back and look at our healthcare system with the lens of health literacy, one of the things it's fair to say, I believe, is that we have a system that's been created by highly educated people, frequently not thinking through all the details of how will this work in public health and in healthcare, how will all of these things work for a person who has this particular type of vulnerability, a person with limited literacy, limited health literacy. And it's fairly easy, without an asserted effort, to end up with a highly educated group of stakeholders who really it's not easy for them to represent the interests and needs of people with low health literacy. So the next thing I want to turn to is how we collect data in patient-centered outcome research. And there's really multiple intersections for this, because multiple people at our conferences presented data that health literacy can have a very large influence on patient-reported data, patient-reported outcomes, and there's a huge problem that can come out of this. So there's going to be a lot of room for improvement in this area. Most of the things that were pointed out at the meetings really were areas where much more work is going to be needed, and really where there's a lot of barriers now to high-quality data input. Part of this can be broken down into to three different buckets. One is the mode of data collection. So if you're collecting, say, for example, survey data, many of our surveys actually have not been validated for use with limited literacy populations, not been validated for use with people who have low health literacy. It's kind of a surprise, but really has not been part of the standard validation approaches. In fact, I have a new R01 in this space with Dr. Jamie Griffith from Northwestern, from the PROMISE team. We showed that there was high differential item functioning for several key items in various PROMISE measures. And if it's happening there, it's happening everywhere, because those are some of the most validated tools around the PROMISE measures. We and others will be working to try to improve the validation. If you have high differential item functioning by literacy, effectively you're entering bias into your outcomes. Whenever there's bias and variability that doesn't relate to the concept at hand, you're just entering noise into your data sets. There are many other types of barriers that, once you open the hood, really become relevant. Linguistic barriers that are related to health literacy and just basic literacy skills relating to syntax and semantics, and things like this, and also language barriers. These will relate to many other phenomena that have to do with the word selection, of course, but also even cultural and conceptual matters. So there are also conceptual barriers. Just as a point of reference, for example, when you're thinking about all of this, research we've done here at Boston Medical Center, about 40% of people could not answer the question correctly. If you have a fair two-sided coin and you flip the coin 1,000 times, what's the most likely number of times it will come up heads, right? So about 40% couldn't answer that question, did not answer that question correctly, and then you think of the types of questions that we ask people. Or, a similar amount don't know that there is a organ in their body called a spleen, or where their pancreas would be, or many, many, many other things like that. And so there's, once you think of, well, the data that we collect, how do we collect it, and what is the cognitive burden we put on people as we collect it, you can start to worry about many of our patient-centered outcome research portfolios. Effectively, everybody points to that pilot testing is critical. I favor formal validation, but there's frequently not enough time as there's been such a creative explosion in PCOR assessments that frequently we don't afford ourselves the opportunity for formal validation, but certainly pilot testing is critical. When items are confusing or not understood, you just get bad data. And, there's typically no simple correction for this. Really, we need to be using modern techniques for instrument development and get rid of items that are not working, that have high differential item functioning by literacy. Just as a comparison, if you have items that have high diff by race, or by gender, we say they're biased items, and we look to get rid of them. And the same standard needs to apply for health literacy-associated differential item functioning. Many of the things that I started to talk about really we could go into a lot of depth for them, and pilot testing is really critical. Similarly for cultural variation. Is your item even appropriate? Is it reasonably comfortable, or does it invoke negative connotations with shame or stigma in the underlying contract? The way you form their questions. Another point about low English proficiency. It is very important for us to get our work out into different populations, not just English speakers, but it's not simply a translation project that's at stake. It's a cultural adaptation project. Translation, providing our work in another language doesn't necessarily solve the health literacy challenges that are in that language, right? So magically doing the survey in another language doesn't magically make the health literacy challenges disappear in that other language. So people have pointed to various types of things that might be beneficial or appropriate, systems that allow people to go at their own pace, systems that don't require reading, staying with standard repeating outcome options, right? If you're constantly changing the answer format, that adds unnecessary burden, cognitive burden, as you change the answer format, Stay with the same answer format over time. Reverse coding. We've shown, some others have begun to show that even though there might be benefit from a certain type of psychometric perspective of having reverse-coded items, it adds unnecessary complexity with respect to health literacy and literacy barriers, and that items that have reverse coding have more garbage, more misunderstandings, in part because of linguistic tricks that we use to create those items. And then there's just the overall response burden issue that many people face in many of our projects. I and many others, we get very greedy to have more data, but of course we want good data. And if you have an overly taxing protocol with the longer you make it, the more cognitive burden you're putting on people, and the more stress you're putting on this factor of low health literacy and low literacy. Again, pilot testing. Another part of this is just the way the lived experience shapes people's responses and influences how people interact with us about their patient-centered outcomes. Mostly people with, and more so with people who have limited health literacy, relates to our conversations and our data collection with a certain type of immediacy bias. There's some data that there's an influence, interaction between limited literacy and this type of a phenomenon. There are other cultural factors that are not really the focus of this talk that influence how people respond in patient-centered outcome measures, things like stoicism and fatalism, and there might be and there's some early data that low health literacy may exacerbate these tendencies, but not so much about that yet. Again, pilot testing is critical. And some of our basic assumptions for how we create these tools in patient-centered outcomes, like the use of Likert scales, and just to imply, assume more familiarity than is warranted. And so there are populations with low health literacy, with low familiarity with these scales, and then the issue of mode I had already brought up, and the opportunities to, as best as possible, as most frequently possible, have orally administered face-to-face data collection so that you actually can support the interaction. Mostly, we've been in the habit of training our data collectors to not interact very much, if at all, with our participants, lest there be interviewer effects to bias participants. That urge needs to be balanced against confusion, and misunderstanding. Because if the patients with limited health literacy don't understand the question, there has to be opportunities to support that, to make it okay, and train the staff, train the research assistants exactly how they actually can support, orient and support patients and participants in our projects so we can have as high quality data as possible. And then there's all kinds of other opportunities to to build cultural variability into our surveys as well, in the language and structure of them. Yep, pilot testing is critical. There's lots of room for improvement, many opportunities with audio support and interviewer-supported interactions for data collection, and then also for mixed methods. In the development of your tools and in the data collection themselves, and the design of multi-methods projects where we actually can make sure that people with limited literacy skills, limited health literacy skills, actually understand what we're asking and are able to communicate what they want to communicate. There's really a great explosion of creative energy for health IT opportunities to have patient-driven data into our projects, but all of that needs to be done with the lens of health literacy. All of it has to be done, what's the coin of the realm in all this IT space is this concept of intuitive design. But what I can tell you from many projects, it's intuitive if it's intuitive for you. If it's not intuitive, it's not working. And the only way to know is to test and to do evaluation, to pilot test your tools, and to develop them with the mindset of patients who have low health literacy and the input of them, and to see what people can do. You can design systems for people who have no computer experience. You can design systems for people who have really limited literacy skills, but it takes purposeful effort, and you don't want your improved tools to only be for the digerati and for the well-heeled. Pilot testing is critical. So there's another layer of this, which is how do we even think in health literacy about our field, and have we adequately represented a patient-centered perspective? So this is kind of the reverse of the last few slides. This slide and I think the next is really to push in the other direction as well. In what ways should the field of health literacy make sure that it can be appropriately focused on the patient-centered perspective? This is an area that I think is also very synergistic and very important and appropriate, and also has a fair number of supporters and adherents, people who've really been looking to do this for a long time. So that I would say most of the intervention work and observational work in health literacy has this mindset already built in over the years. And many of the leading voices in health literacy are people who have done work with PCOR. So that's a good sign. One way to depict this is to think of the overlapping areas that we're working on. The goal is really an empowered patient who gets to a person and consumer who gets to maximize the benefit that they can out of for health in the ways they want. But it will include several layers of issues, from the burden the system puts on it, the burden that the providers have, and the complexity of all the work that has to be done. Ultimately, we have to not blame the victim in this. We have to decrease unnecessary complexity, and at the same time, we have to empower people. This will take massively improving access to education. Every time a clinician interacts with the patient, they should say, where is my learner? How can I empower this person? I am an educator. The root doctor actually means to teach, and we have to find ways to activate the providers to bond with that. Effectively, though, in the end, it will take many other people. It will be a whole team approach. If the medical home is going to fulfill any of its agenda, it will have to find ways to empower and educate and empower the adult learner. And so now I want to turn to the final kind of theme for these interactions, and that is health literacy and PCOR together for our intervention work. When we design our interventions, from the beginning, intervention development needs to include a broad range of stakeholders, including people who have the interests in mind of people who have limited health literacy. We also have to have this in mind when we're recruiting people for our projects. The whole process of engaging populations to participate in our work and to participate in our evaluations of our work needs to include this. If your methods for your studies don't include a mechanism to bring in participants who have low health literacy, then you're missing a very large part of the United States and a very large part of the vulnerable population of target of concern. But you can see still there are many studies that are recruiting online. There's a huge relationship between who's online and who's not. and other types of barriers like that. One of the main approaches in health literacy that really might influence a lot of how people think about this has to do with this concept called universal precautions. With universal precautions, effectively, you just do not assume that the person you're working with understands you until you check and confirm that they do. You know, if you don't care that the person you're working with understands you, well, it's okay. You don't have to check. But if you don't check, you don't know. You know, if I say to a patient, how are you doing with those medicines? And they say, oh, just fine. Frankly, I have no idea. I have no idea. That's just not an approach that will work. We're being friendly with each other, but it's like ships passing in the night. In our intervention work, how we design them, and in our assessments, how we design them, if there's something that you want to know, you're going to have to confirm it. You can't just set it and forget it. We also probably need to give over some control of our love for knowledge the way we do it. More is more. It's not necessarily better. Frequently, more is not better. When we give people now data and information, it's not necessarily empowering. We have to find ways to do both, to bring people up with the information we give them, not to shower them and drown them with the jargon and information that's not empowering. And this actually is a message that's good for everybody. Clear, simple communication is better for everybody, not just people with low health literacy. It's better for everybody. If you look at knowledge gained and knowledge retained, all measures of this improve for people with low health literacy and high health literacy when the messages are clear and simple. With that, we're going to turn towards some time for questions. If people have questions, I just want to point out that we have now started a new journal, Health Literacy Research and Practice. It's live online. You can go to this website and others. If you can send me an email if you want as well. I'm the editor-in-chief of this new journal. We're very interested in having the interests and perspectives of PCOR in the journal, and would love to hear your ideas for that. Also, I can point out we have the next conference. Actually, because I was in leadership with both these meetings, or for planning, that we put them together. So in October 8th through 11th in Baltimore, we will be having the International Conference on Communication and Healthcare and the Health Literacy Annual Research Conference. As it turns out, the deadline for submission of abstracts is April 10th. We'd love to have your work come here, and we'd love to have you there. The ICCH and HARC meeting together will be the largest health communication research-oriented and education-oriented conference in the world. It's about 700 or so or more active investigators and educators from around the world, about a third typically from Europe, and almost everybody else from North America. And I very much, I know that PCOR will be well represented from the stuff that's already been submitted. You can go online and see keynote speakers already. And with that, if people have questions, they can raise their hands online or on the chat box. Thank you for listening. And if you don't put in questions, I'm going to take up some of the topics and continue for just a bit. So we got a question. I don't know if all questions are going to be viewed by everybody, but one question is dementia. So a few comments about dementia. In most health literacy studies, to get into the study, the participant actually had to independently consent, so that at least at the beginning of the study, there was not significant dementia. Many of the authors and investigators in health literacy studies also confirm comprehension as part of the research protocol as part of enrollment. And so effectively, people with dementia are screened out and underrepresented in the literature on health literacy. Accordingly, in most of the data, you have to keep that in mind. There's a few studies that have specifically been focused, though, on this issue of the change of cognitive status over time, longitudinal projects to see about the emergence of dementia and the relationship between health literacy and dementia. Most notably, the LIDCOG study, which now is in its third round of follow-up out of Northwestern, led by Mike Wolf. And there's a series of studies out of LIDCOG. I've also published with LIDCOG data showing the relationship between limited literacy skills and the advent of specific cognitive limitations, in particular in the dimension of executive functioning. I'm not sure if there was if I covered the area of dementia that the question was about. So if the person who asked the dementia question privately, thank you for doing so. If you had a more specific question in that space, I'd be happy to answer. Here's another question that's been put out privately. The question states, there are a number of screening tools for social determinants of health used in electronic health records. Are these being tested for health literacy? Well, to my knowledge, no. To my knowledge, that's another area where tools are being developed but not validated for use with participants with low health literacy. That's another area. This area of screening for social determinants has been a bit of an explosion of interest in this space. It used to be we would just call that, screening for, poverty. If you look at state to state, what items are being included in the social determinants data sets, at least in Medicaid, things like food insecurity, housing insecurity, risk for utilities to be shut off, and so now it's expanding from there. Some states, I think New York State is looking at possibly including a health literacy variable, but in a population way. I don't typically advocate for screening for health literacy. There's one study, a single study out of UCSF where screening was done and evaluated. This was a population of patients with diabetes. They screened for health literacy, and then effectively they put a star on the chart to the doctor if the person was screened to have low health literacy. And there really there's no difference in outcomes. So I'm not afraid of asking questions in clinical context that might be scary or embarrassing. I mean, we do that all the time for sexually transmitted diseases and everything. But we do it when we have an intervention that this information is needed for. If the intervention is good communication skills, if the intervention is clear health communication, confirming comprehension, and teach back, if those are the interventions, that should not be seen as a scarce resource, and I think that should be done for everybody, a universal precautions approach, and not require screening, because screening does have a risk for shaming. There are some studies that show shaming effects from screening on health literacy and some that don't. But independent of that, unless you have an intervention that will only be given to one group and not to another, there's not even a need for screening. And I can tell you from multiple projects, for example, one that I did for patients with asthma, yes, the people with low health literacy had worse inhaler skills, but darn it, loads of people, even many of the people with higher health literacy skills also had very bad inhaler technique, and this is a critical self-care task that I want everybody to be trained on. All right, so then we have another question. Just wondering, why are you using NOL data 2003 rather than the PAC data? Yes, actually, I love the PAC data. Let me see if I can quickly flip over and show and show a slide from PIAC that I really think is very important. I certainly could have used the PIAC data for this purpose, but this is just something that I think is really astonishing from PIAC. Okay, so the question was about this. This is the Program for the International Assessment of Adult Competencies. This was done in 2013, and there were over 166,000 adults from multiple countries, OECD countries primarily. And this is one bit of data from PIAC that I think would be awesome to share with you. So the blue triangles, the arrow tips, that's the average adult literacy skills for a person where both of their parents had education past high school. The white diamond in the middle of those, that's if one of your parents went past high school, and the black line represents if neither of your parents went past high school. What you can see across this slide is in that every country, there's an intergenerational phenomenon in every country whereby a person's literacy skills is related to their parents' educational attainment. But the United States is all the way at the bottom. What does this mean? This means we have the longest distance between the top of between the end and the beginning of our arrow. The longest distance, effectively, this means we have the lowest level of social mobility for education than in comparison to all these other countries. Effectively, we have an educational caste system. It's very much against the way we think of ourselves as a land of opportunity. Yes, we are a land of opportunity, but if you look at these kinds of data, you see that people are tracked in their educational strata. We have less mobility for education than any other country. So I'm glad that the question brought up the PIAC data, and I used it as an example of this. But effectively, when we think about health literacy and literacy skills in general, it's important to realize this, which is that we know people who are special. We know people who are the first person in their family to go to college or the first person in their family to own a house. Yes, we know people like this, but in fact, the majority of people follow the life course that's been set for them. The vocabulary a person has when they go to kindergarten is astonishingly predictive of their life's earnings. Most people, in fact, do not stray far from the path that's been led for them, and many people have been put on a narrow path. The work of empowering people off of that path is hard. It can be done. It is the work of this field. The work of health literacy is tightly bound with the agenda of health equity. Because I'm on, I think there's some other questions. There's a question about, can you talk a bit about how to address the stigma that exists with limited literacy? Many people, when asked if they understand something, just say that they do. Yes, I would tell you that when a provider says to a patient, hey, any questions? The patient knows the answer is no question. How do they know that? They know because our culture tells them that the provider's time is worth more than their time. They know this because they've been shamed. They feel that shame that this question is asking about. I would say that when a provider says, do you have any questions, that this is not an honest play. It's not even an honest play to actually find out if the patient has questions. If you want to know, you're going to have to evaluate comprehension. And we do this the way I promote, many others promote, the teach-back approach. You know, the teach-back approach puts the onus on you as the educator. I want to see if I've been effective at explaining this. Please, tell me how you're going to take this medicine, right? I want to see if I've done my job right. And my job to do it right is to make sure you have actually, show me how you are going to use this inhaler. If you don't care, don't check. If you care, if this is something you want to know, then you have to check. It's a basic principle of QI. It's a basic principle of education. If you know that, if you want to see that you fulfilled the educational goals, you're going to have to evaluate. But you should evaluate in a way that's respectful, right? Healthcare, public health, this is a service industry. We cannot be offending people all the time. It might be shocking to hear, but you know, a doctor say there's a service industry. It's a service industry. We actually are evaluated by how good a job we do. You go to a McDonald's and you go to a fast food place and you say, I want fries and a Coke. After they try to sell you more, can you supersize that? The next thing they say, they repeat your order back to them. You say, oh, that would be fries and a Coke. They do that because they want to make sure they get the order right, because they know they're a service industry, and if they don't get the order right, you're going to be angry with them. The same thing in healthcare. If we want to get the order right, if we want to do this right, we're going to have to evaluate that the person actually understands us. And we're getting to the end of the hour. I just want to, since I'm on this slide deck, I just want to flip to one other thing, and that's this. Okay? You probably, many of you probably recognize this is LA. I like to put this slide up to say the following. One of the things that recommends this field of health literacy and recommends the work of PCOR is all the ways that we look to understand patients and where they're at and what they're doing. So a lot of the studies which I showed some evidence before, for example, the study on mortality, and a lot of things that you can say that many of the authors are doing well is that they are using regression techniques with the data that they have as best as possible to isolate the effect of health literacy separate from poverty, separate from diabetes, separate from access to care, separate from all these other phenomena. But in the end, a person is not a regression model. A person is a person. This is the message from PCOR. And if you want to do something in the world, you know, health literacy goes along with a lot of other vulnerabilities. You cannot go to a person and say, I'm going to intervene with you as if you're a regression model. You have to go and find them where they're at. This is really a core message of PCOR. So in the end, it's not about the regression model. You have to go back to the world and address all of the vulnerabilities that go along with this factor or that factor. Health literacy will give you a path for the intervention. It will show you how and where you are not yet fulfilling your educational mission. But in the end, you have to be brought back to the world where a person is a person dealing with all the other things that they're dealing with. So with that, we're at the end of the hour, and I appreciate your time and sharing this hour with me. The slides will be available. I believe they're going to be connected. There'll be an email out from PCOR with the link for the slides, and there'll also be a link for them on the HARC website. That's the Health Literacy Annual Research Conference website. Again, if you are interested, we would love to see your abstract submissions. Thank you very much.